Conceptual Basis of Urology course, and we will be discussing tonight the Detrusor, that suffers in the hand of an outlet obstruction or a function. We're going to discuss we just waiting for the next few. So this is the 42nd webinar of the Conceptual Basis of Urology course. As you know, that functional urology is a major component of everyday's practice for most urologists. And we are today discussing what happens to Detrusor both in men and in women. Conceptual Basis of Urology course is essentially looking at the contemporary urology, both the science and art of contemporary urology. We are very fortunate tonight to have Ms. Mavish Nadeem, who's a consultant urologist in South Tees in Millsborough in UK. She has done her fellowship from the University College London Hospital, the famous Center for Reconstruction and Functional Urology. I will be discussing first on one of the neurodegenerative conditions, perhaps one of the commonest neurodegenerative condition. And I will just wait for a couple of minutes to start off today's proceedings. And I'll start off with one of the condition called Parkinson's disease. We know that it's a common neurodegenerative condition which is associated with significant morbidity. It's perhaps one of the commonest neurodegenerative condition that we know of. Parkinson's disease has a long protected course. The clinical course and symptoms of Parkinson's disease is divided into premotor or prodromal period, which can be for up to 20 years prior to the actual motor issues. And this would start off with constipation, the REM behavioral disorders, REM sleep behavioral disorders, the extended period of daytime sleeping, hypoosmia, and depression. And this is all prior to the development of the typical motor symptom that we all know of, which starts with fluctuations, dyskinesia, and it can progress to dysphagia, psychosis, and sometimes death from complications that comes. Now, urinary symptoms typically happens between 7 to 10 years after developing the motor symptoms of Parkinson's disease. And we are today focusing on the urinary symptoms related to the Parkinson's disease. This is a case that we recently managed, a 74-year-old male who has presented with complaints of urinary frequency every 2-hourly, nocturia ×3, slow stream, feeling of incomplete emptying, and significant difficulties in initiating a stream. And this is an important symptom that you need to elicit in patients with Parkinson's disease, because that is, and we are going to talk a little bit more about the etiology of this particular symptoms. His IPSS was 18 of 35. Quality of life, according to him, was 3 of 6, which is a bit surprising considering the significant nocturia that he has. One of the major problems that his family also complained of was recurrent urinary tract infections and one episode of urosepsis in the last 1 year. This not only causes significant problems, but is also associated with I beg your pardon. With the aggravation of his Parkinson's disease symptoms, mood issues, and significant. Now, We all know that uh, nocturia is a symptom which is very often associated with BPH. And this is an old ad from one of the British Journal of Urology about over 20 years back, in which they say that women suffer from BPH as well, because every time this gentleman wakes up, opens the light, and walks to the washroom, that wakes up the lady of the house as well. Now, nocturia is a symptom which is not just associated with BPH. We know that nocturia has many etiologies, which includes behavioral issues. Now, this may be associated with disproportionate urine production at all times or during sleep, or it may be associated with low volume of void every time that person wakes up. And this is typically due to bladder awareness with secondary sleep disturbances. It may be a problem secondary to systemic disorders with water salt output issues. It may be a symptom of sleep disorder, which is obviously we know that variable water and salt output, which occurs in sleep disorders. If it is associated with low volume void every time, it is due to bladder awareness due to primary sleep disturbances. And as all urologists, we know that they are often associated with as a lower urinary tract disorder with impaired storage function, increased filling sensation. Now, this is the EAU algorithm for management of nocturia. And it is important to see that the pathway is complex, and this is because nocturia is not just a symptom for BPH, but may be associated with so many things that we have talked about. The polyuria, nocturnal enuresis, and nocturia is a symptom that we're going to talk about a little later in this presentation. Coming back to our patient, we know that his nocturia is affecting his family and himself. Patients with Parkinson's disease is not a patient with an isolated issue, but it is a problem that involves a lot of disciplines. So it's important that there would be some form of cohesive understanding of this patient's disease in order to find the right solution to the problems. Urologist is one of the person dealing with the patient with Parkinson's disease. The treatment of nocturia, well, as I've said, that if it is associated with nocturnal polyuria, is often managed by desmopressin. And the use of desmopressin is extremely effective in management of nocturnal polyuria and nocturia. However, we need to be cognizant of the fact that in elderly male and women as well, use of desmopressin can often result in significant symptoms related to hyponatremia, and which may even result in cognitive disorders and cognitive worsening in patients with Parkinson's disease. So it's important that you monitor their sodium output regularly, the sodium levels regularly in these patients who have nocturnal polyuria or who are on desmopressin. So nocturia in Parkinson's disease is a symptom of overactive bladder as well, which results from the effect on the dopaminergic system, which affects the bladder physiology, result in sleep disturbances. Obviously, it is associated with increased fall risk, with him getting up and going to the washroom from his sleep. And obviously, quality of life issues, not only for the patient, but also his bed partner. Management, as we have said, is careful assessment of the Parkinson's disease status, see what kind of support structure is available, tailoring the therapy accordingly, because patients with BPH versus patients with BPH, nocturia in Parkinson's disease is managed slightly differently, and we were going to talk about it. And it's also important that our management is multidisciplinary, because it's a multidisciplinary issue. So as we've talked about, we need to not only look at take a proper history, see what could be the potential factor. A bladder diary is probably one of the first things that you would like to do before any intervention is planned. And bladder diary will tell you if there is an issue with behavioral disorder, which means that the patient is taking probably much more fluids than he ought to. Once the basic evaluation is done, use of pharmacological agent with particularly helpful are the beta-3 agonist, maybe judicious use of extended release anticholinergic medications, but you need to be a little careful about these things. These medications have significant impact on Parkinson's disease central symptoms. Failure of these may result in use of botulinum toxin or injections in the bladder, sacral neuromodulation that we're going to talk about a little later. The use of condom catheters at night would be, or even suprapubic and periurethral catheters can be one of the things that can be used for the management in refractory cases. So behavioral modification would start off with minimizing fluid, particularly at bedtime. If there is excessive use of caffeine or alcohol, that should be discouraged. It's important that the patient should be encouraged to take plain water for hydration rather than any other fluids. Structured pelvic floor physical therapy with EMG biofeedback, at least for 2 months, have a significant impact on patients' ability to hold urine. If they have dependent edema, which often happens in these patients, compression stockings, elevation of legs in the afternoon, use of diuretics in the earlier part of the day so that they diurese during the daytime rather than diurese during the night. And obviously, as we have said, the external collection devices. As we know that majority of these patients also have significant sleep disorder. So sleep-targeted management is extremely important, which means that you should try and minimize the daytime naps, especially anything which is greater than 20 minutes. Patients should be encouraged not to have those daytime naps. And maintaining a consistent sleep schedule is extremely important in these patients so that they sleep at a particular time, say 9 o'clock or 10 o'clock, so that they have a good sleep in the evening with reducing noise and light disturbances in the bedroom. Compliance with continuous positive airway pressure, which is often needed if they have significant sleep apnea. Optimization of the dopaminergic medication, so in consultation with your neurologist. Sometimes melatonin and antidepressants are prescribed, and since they are available off the counter, so it is not something that is difficult to use. 2 milligrams of sustained release melatonin in these patients can significantly modify their sleep pattern and impact positively on various sleep disorders as well as on the nocturia. Now, when you have this patient, obviously, if they present to the urologist, one of your major concern is to exclude benign prostatic hyperplasia and with resultant issues. So basic evaluation and workup is important. EAU recommends that urinalysis, uroflowmetry, post-void residue estimation, renal function, and some basic imaging should be done in these patients. PSA is a question mark, which should be done in all patients or not. So in our patient, the urinalysis and culture essentially showed aseptic pyuria with few pus cells. His PSA was 6.4 nanograms. His digital rectal examination was essentially unremarkable. His renal functions were preserved kidney function with normal electrolytes. Post-void residue was 105 ml, and ultrasound was otherwise unremarkable. And this is his uroflowmetry, which shows a low Qmax of only 7.54 ml per second. And you can see that it was a small void with over just 150 ml of urine passed in one go. Now, what really happens to the lower urinary tract in patients with Parkinson's disease? There's one of the two things that happens. One is Detrusor overactivity, which is one of the commonest problem in patients with Parkinson's disease. This results from disinhibition of the voiding reflex, and this is essentially secondary to the dopaminergic loss of dopaminergic control centrally. And this would result in significant storage loads both during the day and the nighttime. The second thing which was present in our patient is the difficulty in initiating the urinary stream. Now, this results from a sphincter bradykinesia, a condition called delayed relaxation of the external sphincter and pelvic muscle, or DREE. Now, ICS defined this as an impaired hindered relaxation of the sphincter during attempt, resulting in delayed start of the urinary stream. Obviously, this would be a functional disorder. This results in significant voiding loads, and patient clinically complain of hesitancy kind of symptoms. Now, a question really arises is how to differentiate a functional versus an organic obstruction. Urodynamics, as we know, has significant role. And this particular paper, two types of urodynamic patterns have been defined. So one is a typical of dynamic or functional obstruction, and the second one is a static or organic obstruction secondary to BPH. The Schaefer's define the passive urethral resistance relationship in a collapsed urethra and presence of bladder outlet obstruction during voiding. And the second thing is the dynamic urethral resistance relationship, which affects the urethral behavior when it is not completely relaxed. And in these, particularly the DURR, or dynamic urethral resistance relationship, is a typical finding in these patients to differentiate between the dynamic obstruction and static or organic obstruction. So in this series, paper by Versida and Camaro, published very recently in Urology and Urodynamics, significantly higher frequency of pattern A, about 70% of patient has typical dynamic or functional obstruction and not the typical BPH obstruction. The usefulness of DURR pattern to differentiate between functional and organic bladder outlet obstruction in PD patient was observed in this particular paper. I'm going to show you the urodynamic tracings to see how you would identify the DURR pattern in these patients. So incomplete urethral relaxation during voiding can occur in two circumstances: an increase in urethral stiffness at the beginning or at the end of voiding. Due to increased tone of smooth muscle, urethral muscles, a contraction of external sphincter as occurs in DREE. So DRE is the delayed relaxation of external sphincter and pelvic muscle, a very common finding in patients with Parkinson's disease. This is the urodynamic tracing in one of the patients with Parkinson's disease. And if you focus on the DURR, which is at the bottom of the figure, you can see and observe this pattern. So this is a DUR pattern A, which is typical of functional obstruction, and it is characterized by the presence of 3 or more spikes occupying throughout the voiding cycle. As you can see here at the bottom of the figure on the right side, these green spikes. And this is a functional obstruction pattern. In patients who've got static obstruction, you can see that the pattern is slightly different. And here you have a big spike in the beginning and a big spike in the end with the small little hills in between. So this is typical of pattern B, which is of organic obstruction characterized by the presence of an initial spike and a second spike at the end of the voiding. So urodynamics can significantly identify if your patient has one or the other pattern. Now, how will you manage these patients? Obviously, alpha blocker is a choice and preference. Which alpha blockers be used? There is no great consensus, but this is an interesting systematic analysis, meta-analysis, published very recently in an Annals of Medicine and Surgery, only in May this year, in which they have looked at various alpha blocker use and development of Parkinson's disease. And the author concluded that terazosin, alfuzosin, and doxazosin have a lower risk for developing Parkinson's disease than those patients who are tamsulosin. What about the anticholinergics? Well, we know that the classical side effects of anticholinergics like dry eyes, dry mouth, constipation, cognitive dysfunction are there. And particularly our Parkinson's disease patient at risk for early cognitive decline and dementia with the use of anticholinergics. So it is recommended that lowest possible dose of anticholinergics be taken. And if you look at the various anticholinergics agent, you can see that oxybutynin, which is one of the commonest prescribed medication across the world, which affects both M1, M2, and M3 receptors, have a significant penetration of the blood-brain barrier, and it often results in significant cognitive impairment in patients with Parkinson's disease in particular. So the beta-3 agonist mirabegron is perhaps a safer drug in patients with Parkinson's disease. The adverse events include dizziness and diaphoresis, which is seen in mirabegron. What about some of the other options? And we know that use of vasopressin, particularly if there is nocturnal polyuria, but they should be used extremely cautiously in these patients. Use of botulinum toxin, again, the onabotulinum toxin A or Botox versus EBO are both described in Parkinson's disease. About 30% of patients have complete resolution of urgency and urinate. So these are first-line drug-resistant patients who have been given botulinum toxin. And about 30% have complete resolution. About 80% had improvement in their overall overactive bladder symptoms. The AEs include urinary tract infections in about a quarter of patients, and about 12% required clean intermittent catheterization after use of botulinum toxin. Probably the last line is posterior tibial nerve stimulation or PTNS or sacral neuromodulation, SNM. I have very little personal experience, and maybe Mavish can talk about this a little later. So what about the interventional treatment and patient with CNS diseases like spinal cord injury, Parkinson's disease, cerebrovascular accident, multiple system atrophy, which is a very devastating condition? it's important that we should remember that bladder outlet obstruction surgeries can be safely performed. I mean, previously we used to think that TUR or some of the other interventional treatment may result in significant worsening of symptoms and continence issues in these patients. However, if you have properly selected patients, have a BPO surgery, deobstruction, it is a safe alternative. So it can significantly benefit selected patients. Preoperative investigation is important that indicates that BPE related to bladder outlet obstruction is the cause, and the first-line medical treatment has failed. So, in essence, the Parkinson's disease and lower urinary tract disorder are a frequent occurrence. It's a neurodegenerative condition which affects population above 65 years of age, same age that you develop significant BPO as well. Neural loss in the substantia nigra that causes striatal dopamine deficiency, which results in the bradykinesia, rigidity, and resting tremors, depression, anxiety, and cognitive decline, orthostatic hypotension, urogenital dysfunction, and constipation. So about 60% of patients have some form of lower urinary tract symptoms, which essentially are storage symptoms more frequently, but also the... So as we have talked about, the basic concern is to not only diagnose your BPH in these patients versus functional obstruction. When you're thinking of doing a TUR or other interventional treatment, but also you need to consult your neurologist in order to make sure that we are not confusing the multisystem atrophy, which is a far devastating condition than Parkinson's disease. So it's important that the MSA should be excluded whenever an interventional treatment for BPH is considered. If properly selected, over 50% of patients would maintain their continence. They have significant resolution of their symptoms. Again, the most important thing is to make sure that you made the right diagnosis. So in summary, ladies and gentlemen, lower urinary tract dysfunction is common in Parkinson's disease. Disruption of the dopamine D1 GABAergic direct pathways result in LUTS in PD patients. OAB is the most common lower urinary tract disorder. The urodynamics is important. Detrusor overactivity and minimal PVR if present. Subclinical detrusor weakness during voiding may occur. So it's important that we pick up this thing. Dopaminergic drugs can improve or worsen lower urinary tract symptoms in Parkinson's disease. For most storage symptoms, add-on of beta-3 agonist is helpful. It's important that if the Parkinson's improve, majority of the patients' overall urinary symptoms also improve. So deep vein stimulation, which is considered now as one of the most definitive way of treating Parkinson's disease, is an option. Patients with intractable incontinence can be helped by botulinum toxin. TURP for comorbid BPH and PD is no longer considered as a contraindication, but importantly, you need to exclude the multisystem atrophy. So thank you very much for your attention. And if there are any questions, please post them on the chat box and I'll address them, and Dr. Mavish will address them in the course of this lecture or session. So I move on to invite our second presenter, Ms. Mavish Nadeem, who is a consultant urologist in Southeast in Middlesbrough. She had training in functional urology and recon from the UCLH. And recently, very proud to announce that she was awarded as the Best Trainer Award in Northeast of England. And this nice scope was awarded to her. So thank you, Mavish, for being here. And the screen is yours.
Thank you very much, Prof.
Let me unshare my screen. Okay, so you can share your screen now.
Thank you. So I'm hoping everybody can see my screen.
Yeah, we do.
Thank you. Thank you very much for the kind introduction. And it's always a pleasure to be here. So today I've been given the task to talk about the voiding dysfunction in women, and we'll be focusing on the non-neurogenic type today. It is a very complex definition in a sense that a lot of conditions combine and come under the umbrella of voiding dysfunction. But if we follow the International Continence Society definition, it is defined as abnormal and slow flow of urine resulting in incomplete maturation is defined as the voiding dysfunction, and it should be resulting in a high post-void residual or slow urine flow rates on repeated measurements. And then you can do certain investigations to confirm the diagnosis. And it is often an underdiagnosed condition. There is no concrete data on the real numbers, but if we look at the reported numbers of acute urinary retention in women, is far too low compared to men, where it is well-established condition, and the ratio is 13:1 when we compare male to female. So the question is really, is it uncommon or is it underdiagnosed and underreported? So my feeling is we go with the option B. It is underdiagnosed and underreported. So looking at our practice, I can say that's a relatively common condition with different underlying causes. And unfortunately, it has limited treatment options. But it's important that we diagnose it correctly and we try the options that are available. So it can result from detrusor underactivity. It can be because of the acontractile detrusor. It could be because of the anatomical obstruction resulting in the outflow to the bladder. And it could also be because of the non-relaxation of the sphincter. And sometimes it's a mixed symptom presentation with both storage and voiding type symptoms. And because of this, the history cannot be very clear and it can reach to a wrong diagnosis. So in essence, it's a challenging condition to diagnose and treat. However, the key steps, if we look at that, it's taking a good history and examination, and I'll come to it. This is just a little summary of if we have to look at the causes of urinary retention in women. So we can have causes that are resulting in obstruction and neurological condition that we are not discussing today, but there is conditions such as DSD, most commonly seen as a cause of voiding dysfunction. The functional causes such as Fowler syndrome and high tone non-relaxing sphincter. But it's also important to address any pharmacological agent that may be resulting in the dysfunctional voiding. So how do we diagnose it? Just like any other condition, we have to take a comprehensive history. We look at all general aspects of history, onset of the lower tract symptoms. It is important to assess the bowel and sexual history as well. Essentially, there is a good proportion of patients who present with constipation alongside dysfunctional voiding. We have to look at the comorbids and medications the patient is on. Is it related to the patient's symptoms? And then going on to examination, a general examination and a chaperoned abdominal and pelvic examination. And before the patient come into the clinic, in my practice, I want to see a bladder diary, do a flow rate and a post-void residual. So we have some information beforehand before we start the consultation. So when we're examining the patient, there are a possibility that we find a very obvious cause of difficulty in voiding, such as pelvic organ prolapse, grade 1 prolapse or a complete prolapse, as you can see in the third picture. But it's also not uncommon to see in a postmenopausal female with the new onset lower tract symptoms to have a vaginal atrophy and labial adhesions. And if we address that, some of the symptoms completely resolve. You can have also a condition related to the urethra, so urethral polyps, urethral diverticulum, Bartholian cyst, anything that is causing obstruction at the level of the bladder neck on the pelvic examination. Or simply you can have a completely normal examination, but patients still have symptoms of dysfunctional voiding. So if you look at this clinical scenario, there's a young female who presents to you with symptoms of lower tract symptoms, does not have any comorbid, none on any particular medication, a normal bowel and sexual history. She reports urinary frequency of 6 to 8 times, no nocturia, but she does report urinary urgency, off and on recurrent urinary tract infections. She's trained to void and has a weak flow with some urethral discomfort when she is trained to void. So when you start the consultation, you have a flow rate available that is showing a poor urine flow with Qmax of 10, an average of 8. She voided 250 mLs, and then bladder scan later on confirmed significant post-void residual of 300 mLs. You look at the bladder diary, that almost comparable to the symptoms. She does not have any excessive fluid. She's not taking a lot of caffeine, so that is all optimal. And you examine the patient, and it is all normal. The question is, what do we do next? So I don't know if we can do a show of hand, or we can look at some of the responses. What do the attendees think? What should we do in this scenario? Can try to open the chat and I can see.
Please feel free to give your opinion on the chat box. I will monitor the chat. Mavish, you can continue.
Yeah, sure. So in this scenario, what we did is we look at the modifiable factors to begin with. So we look at the things that we can improve in patients' generic conditions. So it is, she has got normal fluid intake, so nothing to modify there, but she's just training to void. So we wanted to exclude any pelvic floor dysfunction. And in this scenario, pelvic floor physiotherapy actually comes in as very useful option, because a lot of voiding dysfunction is a learned habit. It is due to a lack of facility of the toilet. Women often don't like to use the public toilets. So inaccessibility of toilet is the majorly cited reason among patients. So we can send them to pelvic floor physiotherapists who can not only do generic pelvic floor physiotherapy, but also manual therapy, assessing any tender points, and retrain the bladder by double end time voiding. And at this stage, because the post-void residual is significant, we have to explore patients' ability to self-catheterize. So what are the other concerns at this stage? So because the bladder, it's a long-standing history, she's giving you a history of about a year or two. She has got significant post-void residual. And in women, it is not as common as I previously stated to see this sort of condition. It is important to assess with an ultrasound. And this is coming, yeah. So we do ultrasound kidneys to see, exclude any hydronephrosis or pelvic ileal dilatation, and also any pelvic mass that could be resulting in the difficulty to empty the bladder. You can also check renal functions if you're concerned based on the ultrasound findings, because of prolonged urinary retention that can have an impact, specifically of a patient with comorbids. So you did all of that. You send the patient to pelvic floor physiotherapy. Patient came back and told you that, well, I was some symptomatic benefit, but nothing major. You check post-void residual, it's almost unchanged. Renal scan, abdominal scan, renal function, everything is normal. And she tried to do self-catheterization, but she found it really painful. She attempted, but she could not do it. So what do we do next? Because she's finding it painful, it is really difficult to decipher. It is because of pelvic floor dysfunction. Is it difficulty in relaxation of the sphincter? Or is it because of anatomical obstruction? And one way to exclude that is to do a cystoscopy. And it is difference in practice. There is no consensus document what you should do first, but essentially both cystoscopy and urodynamics come in handy. Cystoscopy, there's a debate whether you should do it under GA or LA. If the patient is finding it painful, in my practice, I would do it under general anesthetic. So I can properly assess the urethra. I can look at the bladder capacity, exclude any abnormality, and also it's a good opportunity to do a proper pelvic examination and a speculum examination. So I did a cystoscopy. The urethra was normal, so I can put this scope without any problem. There was no pelvic pathology. And on bladder examination, the mucosa overall looked normal, but the bladder was trabeculated. So you can appreciate the trabeculation, indicating that there is some obstruction. So at this stage, we have excluded any pelvic pathology causing physical obstruction and also any urethral abnormality. So at this stage, the question is, would you offer urodynamics? And the answer lies with the basic principle of urodynamics. If your urodynamics is going to change your management, by all means, we should do urodynamics, because we need to know either you're dealing with a good detrusor or you're a poor detrusor. So this is a urodynamic test that we did. And you can see this is the abdominal line, the first one. The blue is the vesicle and the purple is a detrusor. And on attempt to void, you can see the patient is generating reasonably good pressure of about 45. And the flow is really poor. And it is almost similar to what you find in the bladder outlet obstruction in men, secondary to prostate enlargement. But of course, you have done a cystoscopy, so you know you're not dealing with a physical obstruction. So what you're dealing with is a functional obstruction that could be due to pelvic floor dysfunction or a problem in the sphincter, and because of which the patient cannot void. And this is the urodynamics video, which you can find that the bladder is trabeculated. You can appreciate the trabeculae. And then you can see the pooling of urine in the urethra and a complete cutoff. And if you have this finding to begin with, you might think, am I dealing with the urethral stricture? But of course, you have the cystoscopy, so that is not the cause. But it can be a very confusing situation if you start with a urodynamics, and you might think. So there is no right or wrong answer whether you do cystoscopy first or urodynamics first, and it's also based on the facilities you have, so you can decide accordingly. And again, as Prof. Athar was alluding to, that it's important to take the MDT input in these situations. So these are few nomograms that we use in female bladder outflow obstruction. So it's a Messi and Abrams, female Liverpool nomogram, Detrusor, and female bladder outflow obstruction index, also called as Solomon and Greenwell nomogram. So in whichever nomogram you try to fit in, the flow rate in this patient is less than 12, and detrusor pressure on voiding is over 25. And even if you look at Abrams' definition, it is clearly fitting into a female bladder outflow obstruction. Now we have a diagnosis. Do we need to do any additional testing in terms of urethral pressure profile or electromyography? If you ask me, it's more of academic value. Despite I have access to this, I don't do it at regular because, again, the question go back to the basics. Is it going to change my decision about patient management? If the answer is yes, we should do it. If no, then we just proceed with the management. However, for the sake of teaching, I'll show you one of the picture that you may get, specifically in Fowler, where you have the increase in the signals of the surface EMG. So it is due to the hypertrophy of the urethral muscle, and you can see the increased signals on the surface electromyography. So this is the sort of picture you would expect. In general, it has to be a silent electromyography, but because of the increased pressure, you will see this increased signal values here. So what do we do with this patient? One option is we give another try and see if the patient can do self-catheterization in more supportive environment. What comes handy is the specialist nurses. Sometimes they provide support to the patient, relax them in a more warm environment where they can discuss their concerns. However, unlikely it is going to be successful, in which case it's good to take it to the MDT and see what the MDT would recommend. Essentially, looking at the options, we have option of trying sacral neuromodulation. We can have a urethral sphincteric Botox, or we can think about urinary diversion either in the form of suprapubic catheter, because of course you don't want to put an indwelling urethral catheter. It's going to be very painful and has got its own consequences in terms of urethral trauma. And more advanced options such as mitrofenov, which we all know that has got very high revision rate, and conduit. And in my practice, I have done 2 conduits for these patients where none of the above option actually helps the patient. And alongside this, obviously, it's important to look at the other things that's going on alongside, such as the urinary tract infection management. And once you deal with the bladder emptying for residual urinary frequency and urgency, you can always prescribe anticholinergics. So sacral neuromodulation, let's discuss the first option that we often offer to these young females after discussing it, the MDT. It has got excellent, good to excellent response depending on various conditions such as Fowler and high tone non-relaxing sphincters. It's about 90% response rate, which is fairly good. And if we look at the mechanism is based on the S3 maturation center. So S2, S3, S4 keeps it off the floor, and it is offered to the patient both for voiding and the defecation dysfunction, because the center is the same center. There are 2 different types of neuromodulators. It's a Medtronic and Exonics, 2 basic companies. One is rechargeable and one is recharge-free, which is Exonics is recharge-free. And if we look at the development of neuromodulation, it has come a long way, because previously, if somebody has got neurological condition, you could not offer neuromodulator, but now you can, because they are all MRI compatible. So it has come a long way and provides a great response for the patient. And this is the other option, botulinum toxin into this external urethral sphincter. We published it back in 2022, and we look at the functional outcome basically. So we are giving 100 units of Botox diluted in 2 mLs of saline, and we give it in 4 aliquots at 2, 5, 7, and 11 o'clock at the under the direct vision. And if you look at the response rate, overall 70% patient responded with a good symptomatic improvement. However, it was a short term, and only just under 50% of the patient requested for a second injection. And on long term, 30% patient wanted to continue with this treatment. It is because of the short-lived nature, and it is not curing the problem. It is only reducing the need of self-catheterization, relaxing the sphincter to the point where patient does not feel as much pain as they were feeling before. So it is more of a management of option rather than a cure of the problem. So the question bounces back to, what do we do with the poor detrusor? For example, this is the scenario where your patient had detrusor function. So you're trying the patient to void. But we have seen in our practice that even if you start off with a good detrusor, but if you leave it untreated for a very long time, it turns into a hypocontractile or acontractile detrusor. And what do we do with these patients? So if you're not dealing with a painful urethra, essentially most of the patients are better off doing self-catheterization. But we have to understand that in the long term, it could be a problem, because as they grow older, they have got less manual dexterity, cognition. They cannot continue like that for a long time, in which case we have to go back to the options we have discussed before, such as suprapubic catheter or trying the neuromodulation or sphincteric Botox. And in a desperate situation, we can think about more radical options. But it's really important that we discuss this with the patient and understand their expectation out of this treatment. In summary, I believe that voiding dysfunction is often an underdiagnosed and underreported condition. And as a urologist, it's really important that when women are coming to us with incomplete bladder emptying, we should assess them fully and comprehensively with history and examination. We should send them for pelvic floor assessment, physiotherapy, and bladder training, and do the diagnostic tests that are going to take their management forward. and do a shared decision making by understanding their wishes and expectation and tailor the treatment options based on that. Thank you very much.
Thank you, Mavish. A very comprehensive overview of avoiding dysfunction in women. In response to your question, majority of the participants have mentioned both cystoscopy and urodynamics as possible intervention after initial workup. When you ask or when you do a cystoscopy and you do urodynamics, what specific questions that you have for either of these two interventions and what you're trying to answer?
Thank you, Professor. During cystoscopy, the most important question is, are you dealing with a functional obstruction or it is an anatomical obstruction? And as I alluded to before, you're looking for the assessment of urethra because there's some misconception that you should do urethral calibration. So it is important that we should not do any harm to the patient. So if your 22 French scope is going in without any problem, there is no need to do the dilatation. You have the answer that the urethra is patent, but also look for any other pathology that could be relating or explaining the patient's voiding dysfunction. So assessing the pelvic floor, assessing any vaginal mass, for example, that could be causing the obstruction to pass urine. Similarly, urodynamics, you are not only looking for the voiding phase. I did not discuss about the filling phase, but it's also important to see the fillings. Are you dealing with the detrusor overactivity? Is there any loss of compliance? So are you dealing with one pathology or there are multiple pathologies? Because when you're designing or discussing the management options, it is important that you have a comprehensive overview and you are dealing with both problems. Because if you deal with one and you leave the other alone, the patient is never going to be satisfied.
Another condition, Dr. Mahesh Adhikari from Nepal have asked this question about the indication and use of dentrolene, which is a skeletal muscle relaxant, to help relax the urethral sphincter, in particular with patients with DSD when your options are relatively limited. And any comments on that?
So for neurological patients, we do use some muscle relaxant and it is found to be helpful, but not in the non-neuropaths. Often we try to deal this with the pelvic floor manual therapy, and that's helpful. But also there has been instances where we send them to the pain team if the pain is significant, in which case they inject some of the muscle relaxant directly. And there is a growing evidence of actually injecting the Botox within the pelvic floor if you're dealing with the pelvic floor pathology, in which case it relaxes the pelvic floor so the patient can void and defecate more easily.
There's some questions about urethral stenosis, although we're not specifically dealing with this, but there are questions about what do you do in cases of Chandra Yadev has asked this question about how would you deal with urethral stenosis? Is dilatation the only solution?
So that's a very good question. And urethral stenosis, we have different scenarios. And often what we do is we do dilate and it recurs. We all know it will recur. So the optimal management is that we do first dilatation and start the patient on intermittent self-dilatation to prevent the recurrence. But beyond second dilatation, I would think that is going towards more of reconstruction, where we should offer the patient urethroplasty. In female, the evidence is there. EAU guidelines support the vaginal onlay urethroplasty, and increasingly we are doing buccal mucosal graft urethroplasty. And in young women, essentially we are looking for more definite option rather than keeping them on long-term dilatation.
So about use of topical estrogen creams in postmenopausal women, is that also helpful?
Absolutely, absolutely. So it is really important that we give a comprehensive treatment to the patient. So when we're looking at the modifiable factors, such as in the index patient I was discussing, if she has recurrent infections, it is important that we address everything. Vaginal estrogen cream definitely has a role. And one more thing I want to highlight is that we have to look at the age of menopause. So in Asian countries, the menopause age is around 45, and the perimenopause starts at about 35. We all know it starts 10 years earlier. So if you're seeing a patient with new onset overactive bladder symptoms, new onset urinary tract infections, then you must think about, is it because of the low estrogen level, in which case vaginal estrogen gives a really good treatment response.
Right. So you've mentioned about the pelvic physiotherapy, and I've also talked about the EMG, particularly if it is electrical stimulation for a long period of time in patients with Parkinson's disease. The pelvic physio is essentially starting off with basic physio and then moving on to the electrical stimulation. What is the typical way you do deal with these patients?
Thank you. So we have got a pelvic floor physiotherapist, and the way she does it, she generally offer the pelvic floor physio as you would do general, but also she make the assessment in terms of any tender point and do a manual therapy with a biofeedback TENS machine. And the TENS machine sometimes relaxes the pelvic floor, and this is combined with the biofeedback and bladder training. So they have a full comprehensive assessment and management with the pelvic floor physiotherapist. And we have to give at least 6 weeks of treatment before the patient come back to us for further evaluation.
Yeah. I'm never been a fan of Bethanycol for hypocontractile bladders. And we do often see patients being put on Bethanycol with side effects alone. So what is your opinion on Bethanycol?
I share your view. So
Okay,
I don't think so because of the side effects mainly. It is not licensed here in the UK as well for this indication. So it's not part of the practice.
PTNS, and any final words about when and why you use PTNS?
Absolutely. So PTNS does have a place in this whole algorithm. And often PTNS is combined with other things, for example, pelvic floor physio, biofeedback, and PTNS, because the mechanism is sort of in the same line as the sacral neuromodulator. You're just stimulating the posterior tibial nerve. But I do quote the exact success rate that we know of, it is less than 50. So I wouldn't quote anything more than 40. And when you tell the patient 40% with PTNS and 90% with neuromodulation, depending on their choices, I will go with that, but definitely it has a role.
Okay, I think that's about all the questions. I just last one by Shaukat Fayaz, and he wants to know what is your regime for giving vaginal conjugated estrogens.
So the vaginal estrogen cream, we have 0.1% concentration of vaginal estrogen cream that we give the patient to use once daily for 2 weeks, followed by twice a week on long term. And if the patient is responding, please do not stop it and see what happens. It will get worse. So if they're responding, just leave them on the long-term treatment. I understand there is a concern about breast cancer, uterine cancer, but Lancet has recently published the data. I think it was in June 2024, Lancet, and they actually looked at the use in breast cancer survivor, and there was no increase in mortality. And a full 1 year topical estrogen cream application is equal to 1 single tablet of systemic use. So that's the answer. You can use it for long term.
I think there's increasing evidence about HRT now, and some of our initial fears have been tackled by the data coming up. But definitely the topical conjugated estrogen is perhaps a very safe alternative. So, Mavish, thank you very much. And thank you for responding to our invites, which we do trouble you once or twice a year. It was wonderful to have you. And I'm sure that our audience must have a very clear opinion about some of these difficult aspects of dealing with these patients, both men and women, with voiding dysfunction. So thank you very much. Have a very good weekend. Good evening to all of you.
Thank you very much, Prof.
Thank you.
Lovely to be here. Thank you.
Thank you. Bye.
Bye.